now to validate the CTV from Johns Hopkins. So when they looked at their deviation versus no deviation for the CTV based on what we did many years ago, they actually showed that your failure rates will increase if you don't follow the guideline. And I'll show you where that comes to be important. But this is important research that you can do anywhere. When you start looking at your experience, patterns of failure is extremely important to guide practice. And where we're getting so good in terms of imaging and understanding that even if you have a posterior element alone vertebral metastases, you can actually exclude the vertebral body. And that we never would do clinically with conventional radiotherapy. And we published this data. Laura Burgess, who's my fellow right now, when she was a medical student, just looked at her experience and published this technical report on how do they fail when it's only in the posterior element. Again, validating the clinical consensus guidelines. Now, one area which is difficult, and what's important for you all and your patients, especially when you see metastases, is to the sacrum, because they're non-surgical, they're extremely painful, and they're big and they're bulky. So the first thing that we did was said, okay, well, let's figure out, how are we going to do it? And this is how I was doing it initially. So I would do and follow the principles of a CTV. Now, many people were doing just GT. So we published guidelines, again, contouring consensus guidelines. And then we looked at our practice over the years, whether or not you deviated or didn't deviate. And we just had this accepted in an article in the press that if you under contoured, your risk of failure really dramatically increased. And this was a very controversial area in terms of practice, because many people thought the sacrum was like any other bone. It wasn't like the spine, but the same principles apply. And so again, important to standardize practice when we talk about global adoption. Now, the spinal cord was also a difficult area in the beginning. This was the area that everybody was afraid of. We didn't want to cause radiation myelopathy. And there are different ways of drawing the cord. And I think as the imaging has gotten better, many places do cord alone. I do cord plus 1.5 millimeters. In the beginning, we had to do the thecal sac and take into account the CSF and the spinal cord, because you just couldn't see it, and the fusions weren't good. But now I think very comfortable only cord PRV. We still do the 1.5 millimeters and below where you have no cord. Because remember, the spinal cord ends and you get your thecal sac, your cauda that's where you have to draw the thecal sac. So these are kind of the concepts that sometimes we don't really think about when we're starting, but we've outlined it for global adoption for practice. So again, important for us to think about these issues before we get onto a program. Now, what about the dose limits? Well, this is where initially we were very conservative. And even the MD Anderson, I think it was almost 8 gray in 1. I mean, it was a very low dose. Even though they knew they could do it, they didn't want to get into complications. So I had learned from my mentor, David Larson in San Francisco, to start escalating things. And we started pushing the limit. And ultimately now we have a very good balance in terms of where you can go. In terms before you start the inflection point on the normal tissue complication probability curve. So the way that we do this now is that if we want to take a lower risk with 2 fractions, we did 18.7, but we have a higher limit now with high tech that allows you to push it, because these patients have epidural disease or risk of cord compression. The majority of them are not living 10, 20 years where they're going to develop radiation myelopathy. You really want to try and improve the disease control, even in the shorter term. So you can take some risk, and it's a low risk. In the re-irradiation, this is where it was a little bit more difficult, because in re-irradiation, there's some work I did many years ago that really there's been nothing more since. And Majid just reviewed the data for me for a book chapter we did, and there's nothing new. So it's my experience really that's guiding the increase in our tolerance of re-irradiation. We'll publish the data, but we have escalated and increased the cord tolerance beyond what we did many years ago. So there's room in particular in re-irradiation. My general rule of thumb and what I've thought of in re-irradiating, fully fractionated, hypofractionation, is you probably get about 75% repair within 6 months of your neural tissue. And that's what I think is happening in the spinal cord. It's never 100%, but it's much more than. So where are we in terms of the trials? Because I can tell you all the data, but you're not going to believe it until you have a randomized study. Because that's the way medicine works, right? You're making big changes for a large number of patients. You have to do the randomized study. When you look at pain as an outcome, it's very hard with a patient-reported outcome as opposed to overall survival, which is a hard endpoint. But we did it, and we said, okay, we developed 24 grade 2. We treat a lot of 20 grade 5 with conventional, and we're going to do the study. So we randomized patients with a painful spinal target that will be in red. We allowed up to 3 vertebral metastases to be included in the field. And we said, okay, we're going to treat you and we're going to follow you and let's see what your pain response is. And some people said, well, why did you choose pain? Why don't you choose local tumor control? Well, the first question is, can we improve a patient's life at the end of life? And that's pain control. So if we improve a complete response rate for pain, we're doing good. If the byproduct is better local control for those who live, even better. So this was the first study this is the main study that we did. 229 patients, we randomized them. Normal randomized control trial, excellent quality assurance, randomized within a year and a half. The majority of patients were either prostate, lung, or breast, which is our normal that we see. And we followed them. And Majid and Hang were both with me at that time. We were randomizing actively on this trial. And it wasn't that hard to get patients to participate. And we followed the painful site. And what did we see? We saw what you see in the first, 14% rate of complete response rate with conventional radiation, 35% with stereotactic, and that held true at the 6-month assessment. So now you're talking about a 20% absolute improvement in pain control. That's 1 in 5 will have no pain more than if you treated with conventional. So that's important. And your overall pain responses are better. And there's a real benefit to patients at that stage when there's nothing else that can palliate a patient's bone metastases like radiation, not drugs and certainly not surgery. So what were the adverse events? So we wanted to make sure we weren't hurting patients. We looked at the adverse event profile and a very low rate of serious adverse events of grade 2, 3, or 4. And we had 1 serious fracture in both arms. So overall, you had no difference in the fracture rate. We always quote 10%, and that was seen in the trial. And we had a very strict quality assurance guideline to make sure that the treatment plans are correct. Because if your quality assurance isn't there, then your data is not good. So in conclusion, we said that we're getting a 21% absolute improvement in pain control. We also note this is the first phase 3 randomized trial to even show that it actually matters if we give more dose for bone metastases, because all those trials with conventional radiation were negative. For so many years, so many thousands of patients were randomized to 8 grade 1 or 30 grade 10 or 20 grade 5. It was safe and non-destabilizing. So that's the randomized study. And then the next question that comes, and many people ask, well, 3 months, 6 months, for the pragmatic aspect of the trial, we only follow patients to 6 months. So the question then becomes, how did they do in the long term, right? And so we looked at our data in Sunnybrook. And because we randomized 137 of the 229 patients, and I followed them with MRIs every 3 months in clinical follow-up, we could look at our data. So we retrospectively looked at that cohort. And what we found is that of the 119 spinal segments that were included in SBRT, 169 in conventional, because now we could actually count every single level that we treated in the treated field, not just the target volume, but everything we treated. You saw a better local control. You saw less re-irradiation, okay, and that's important for our patients. And you saw similar rates of fracture. What we did see, and we'll come to this a little bit later, was that if you had paraspinal or epidural disease, so more bulkier or mass type tumors, not just confined to the bone, your rates of failure increased. And they also increased in the SBRT arm. So let's just talk a little bit about fracture at this point, because this is an important adverse effect for patients, and it can be terrible, destabilizing, and put some patients at risk of needing more procedures. And at the end of life, you want to limit how many procedures you're doing on these patients. You want them to enjoy their quality of life when they're in a terminal state. So if you look at our fracture events, and we had 22, this is where we broke it down to those that were iatrogenic, associated with no local failure, versus the patients who had local failure inducing the fracture. Because if you're progressing by the tumor, you're also destabilizing the bone. And the main thing here is that if you see here in red, the only grade 3 main side effects were in the iatrogenic. So if you hit the vertebra that hard and the tumor is essentially fully treated and you see the response of the tumor, we also necrose and destabilize the bone. So it's a small risk, but it's something that you need to consent the patient. But it's a small risk. Now, the other main randomized study was RTOG 0631. So this is the American study. And this is many centers in the US, or centers in the Middle East, in Saudi, I think in particular, who randomized to this trial. And this was a hard study. It accrued over many years. It didn't have the benefits to the design like I did, having learned more along the way, and it was a negative study. They saw no difference in pain response over here, no difference in complete response. But this was prior to them understanding really what instability meant. They used a very different definition of pain syndromes. They had a variation of patients with higher or lower performance status. They had a lot of fractures and they had a lot of failures. So what I say is that all it tells you is don't use that dose. That's all it is. That 16 and 1 is too low. There are some centers that still use it, but they're changing and moving along. And so that's what I think we learned from 0631. We also didn't get the quality assurance metrics from the study. Okay, so now we've got some data. We have a randomized study. We say, okay, we're going to give everybody stereotactic radiation. But that doesn't really work that way, right? We are in the era of personalized medicine, and we want to personalize the approach. So the first thing that we wanted to do is really understand the impact of histology, right? So you have the patients who are radiosensitive versus radioresistant. And I thought at that point, okay, well, let's look at our data. So we had a good number, 395 segments that were radioresistant. And I said, well, let's look at prostate, because I think there's a variability in breast, and maybe I'm not right on that. But prostate is sensitive. I mean, like, there's no reason why I shouldn't respond. So I said, let's compare it. So what do we see? Well, we see that there is still a greater rate of failure in those radioresistant, still pretty good, 80% local control. And we saw the prostates being far better, but we also saw this creep that started happening in local failure. We said, well, why that happens? Prostate cancer, right? Well, then we looked at our data again. These are all my fellows that over the years that have been able to publish and understand and help us understand what's going on. And what we found was in those hormone sensitive, you had like no failures. In fact, I don't even know if we should be treating them with stereotactic radiation unless they're oligometastatic. And then you have your castrate-resistant group over here. And over the years, if patients with castrate-resistant prostate cancer live, they start to respond like a radio-resistant histology. And it made perfect sense to what I was clinically seeing. And you can stop me anytime if you have any questions. So then we started saying, and I thought about this some years ago. And I said, well, look, how do we do better with that? Because I'm still not giving 24 and 1 like Sloan Kettering says they do. I'm still in a lower dose, right? 24 grade 2. And so we had done some mathematics before, and we kind of thought about a model, and then I worked with the group for the high-tech model. But I had actually escalated to 28 in grade in 2 fractions many years ago. In fact, while we were doing SC24, we had already started off trial offering higher dose of radiation, particularly to radioresistant. And then we modeled the data, and it was looking like the math was right. And if I wanted a 90% local control rate, I had to give 28 and 2. So this is the high-tech curves. And again, it's a model, right? So is the model true? Well, we were actually very lucky. And we looked at our 28 in grade 2 data versus 24 grade 1. Again, this is a resident of mine, Liang Zheng, who wrote this. And we had 300 segments treated with 28 and 2, about 650 with 24 grade 2. And what we see is the local control curve showing better local control. So we validated the idea that we could do better by giving a higher dose per fraction and a higher total dose. And what was important is that when we modeled the data, we fit right on the curve. So we validated the curve. So dose escalation is real. It actually matters in bone mets, and we maintain the same rate of fracture. But we do have to follow up on this because it was still early on in terms of the follow-up for the 28 and 2 cohort. So I'm cautious about that, data. But we're showing that dose matters. And I think that's an important concept at the end of the day for these patients. Now, not every patient can get 24 gram too, and you may not feel comfortable. There are some which, like, I'm not even sure. They're big mets, or we're treating 3 consecutive levels, big bulky paraspinal disease, or in the sacrum. And there we start saying, well, like, you just hesitate because you don't know 2 fractions. It's still 14 gray per fraction, right? It's a huge dose. So for the bigger ones, we were give 30 grade 4 fractions. And Daniel Moore-Powell-Harris reported our experience, and we were treating for a fraction SBRT. And it's convenient because if you start on a Tuesday, at least you end on a Friday, right? You've got 4 days of treatment, and that's practical. So how do we do? We did pretty good. We got about 16% failure rate at 2 years, low incidence of vertebral compression fracture. And then what we saw, and we don't know yet, is that for these smaller volumes, less than 72 cc's, we saw 0 fracture. So all the fractures were happening in the much larger spinal segments with disease. And I have to know, and I don't know yet, whether or not further de-escalation of the dose per fraction reduces the risk of fracture. And it may be a balance between local control and fracture, but we don't know that answer yet. Okay, and then we get the post-op. And I think this is a good area if you're radiation oncologist, you're interacting with the surgeons, and you say, well, look, they just did a big surgery. Like, I'll give post-op SBRT. And this is all the work that we actually did initially. Most centers started with retreatment or de novo. We actually mainly started with post-operative. We did a lot of the background work, the physics work, the imaging work, looking at how we drive, and we built the story for post-op SBRT. And that's when Majid was my fellow, and he wrote the paper actually defining the impact of epidural disease. So it was actually validated as a result of our work looking at our post-op SBRT rates of failure. So we had 80% local control, which is really quite good. And this is the issue. If you have high-grade epidural disease post-operatively, your rate of failure is high versus if you have low-grade or no epidural. So the surgery matters, your post-operative volume matters, and this was important data because some centers like Sloan Kettering and maybe even Cleveland Clinic had already started doing routine separation surgery. And separation surgery is not an inconsequential approach for a patient. Like, you're putting them through a major operation, you're debulking the epidural disease, and we never had the data to prove that it mattered until we wrote our experience out. So we do routinely for high-grade epidural disease decompress when a patient is oligometastatic and we think they're going to live at least 6 months or longer. Otherwise, the surgery is quite significant. But the surgical trends are changing. There's less morbidity, but there's always morbidity. So you just have to be careful. So what's the prospective data? There's no randomized data, but there's good prospective data from Japan, and they use our fractionation scheme that showed, again, 80% local control in the long term, so really quite good, and very good functional outcomes over time in terms of quality of life, ability to retain walking, and good local control. So I was really happy to see at least some prospective data in this regard. Well, how do you draw it? Well, again, it's much more complex. It's much harder to draw a post-operative clinical target volume than an intact, but we have some guidelines to help practice. The main thing is, if you don't know, you have to look, because this is a case that somebody sent me from New York, and this was the preoperative actual tumor, and this is what they were planning to treat. And they called me, and I said, yeah, sure, send me. And then, but we had to stop the treatment because this is completely wrong. So all of these guidelines exist in order to help guide practice. And I think that's the most important thing, is draw the right CTV. Forget what dose you use, because we don't know what's truly optimal, but you have to draw the right CTV. And then comes retreat. And again, it's important for large centers, like for yourselves, when there's commuting practice and non-commuting, because they radiate palliatively and then they send them to you for re-irradiation. Because and then I understand why, and it happens. But we have very good retreat experience that Jay Desky, who is my fellow now on staff, he's reported. And we see very good rates of local control, But, you know, there were factors at that stage. So if you have neurologic deficits, certain histologies and brain mets in particular, they're not living a long time. Usually they're more at the end of life when you get to re-irradiation, SBRT, but it's still occurring. So how do we put it all together? Let's say I have an optimal case. So this patient of mine was very early on in my career, had lung cancer, and had just minor epidural disease. It was like a 1C, you know, starting to get to a 2. She had some pain. So I said, okay, you know, I want an operation here. I want separation surgery, but I'm not going to put her through a big incision and a month of rehab. So now they started developing minimal access spine surgery. So through a keyhole, they can actually go in there, decompress the epidural disease, sew it at a 2-centimeter incision, and then 3 days later, I can simulate her. And you can see the surgical tract here. By 7 days, she's planned. By 10 days, she's treated. And that's how fast of a system we're developing for these types of unique patients that fit that oligometastatic, previously radiated, and you need to do better. So it's an evolving state of affairs, how we interact with surgery. Okay. So now I've shown you kind of some of the single institution where we're going. It's stereotactic body radiotherapy for spine is here to stay. It is not going anywhere. It's only increasing globally in its adoption. But we have to be aware of some of the subacute and related toxicities and why they happen. So one of them in particular is fracture. And we did some very, very early work. And Amin Al-Omer, who's in Saudi right now, was part of the team actually when he was my fellow. And he's very proud of this. He worked very hard alongside my other fellows to actually report our experience with the MDA in Cleveland Clinic. And this was the defining paper showing vertebral body collapse, if you've got kyphotic deformity, lytic tumor, and your dose per fraction matters. So if you have a patient like this who doesn't need surgery, but you're going to treat with SBRT and has lytic tumor in the cervicothoracic junction and already kyphosed, you better be careful because she's at 40% risk of collapse and may need surgery. And so one of the ways to try to mitigate that risk may be to dial down the dose per fraction. And this is where Sloan Kettering and our group were having a lot of clashes between the fractions. We didn't like 24 grade 1. I was doing it, but we had 40% risk of fracture. Then what I do was just 12 times 2 or 14 times 2 is 10%. And then if you're at 21 like Pittsburgh, you're getting about 20% risk of fracture. So, you know, we proved that the dose matters, not only in terms of tumor control, but with respect to reducing the risk of fracture. Now, most of us were seeing fractures early on, and then we started to see this late fracture. And this is an interesting bimodal type of distribution. So why were the late fractures happening? Because the acute fractures are mainly destabilizing, but the late fractures were interesting. And part of the way that we started to understand this was because this was a patient of mine with EGFR lung cancer on osimertinib, had complete control. I gave her stereotactic radiation. This patient, like 2 years before significant changes, this was her MRI 6 months post-treatment, and then 2 years. And she started fracturing, she had increased T1 signal change. They said, this is tumor progression. I said, there's no way. Her disease, they're responsive to drug, let's biopsy. So we biopsied and we saw radiation fibrosis and necrosis, just like we would do in the mandible with head and neck. But we see it also in these late survivors. And you could say, well, you know, yeah, that's intuitive, we know that. But at this time, we didn't really know how to interpret MRI of the bone. And I really don't think we still do. We're still evolving in this nature. So some of the questions are, can we do better, right? And so one of the areas of active investigation, this is what UT Southwestern does, is they prophylactically cement. So somebody who comes in who's going to get SBRT and bad pain, but no fracture, they actually cement it. And that's hard to do in off trial for sure, but even ethically, because they don't have a fracture. So most places won't do it, but they did it on a trial. And as long as you're on a trial, that's okay and already approved. And what they found was very good pain response rates. So their 3 month pain response rate was better than historic 95% versus 51%, which is good. And they were not that unstable. And I got the SINS data from them. And overall, it shows you cement is being used more and more. And it may be a very important means to mitigate some of the risk of further fracture, or what's going to be starting to be understood more and more as a new complication to consider. And this is work that I'm doing right now, which is starting to understand the change in the alignment of the spine as a result of stereotactic radiation. So we're weakening the bone. In this case, we treated 2 levels. You see it, we actually cemented because she had some fracture. And then over time, she's still kyphosing more and more, right? And so cement can maybe help reduce or slow down the pace of kyphosis, but at some point, some of these patients are actually going to need surgery. So this is an area that we're thinking, but I think cement is very important. The way that I use it is if they have mechanical pain and they're post SBRT, I cement, or if they develop a fracture, we consider it if they have mechanical pain, but I'm very clear. It's just that I haven't adopted prophylactic. Now, another important area for understanding this program is the nerve root. A lot of people say, well, what about the nerve roots? The spinal cord is okay. We don't spare the nerve roots. The one area is, and this is where we're evolving in our practice, and again, really late in terms of understanding this, is how to deal with the brachial plexus and lumbar sacral plexus, and what do we do about it? Initially, we just didn't care. We just gave the radiation, we said it's peripheral nerve, it's okay. But we have started to really understand the issue of plexopathy. So if people are going to live, and this is a cohort of patients who survived more than 3 years after stereotactic, so 605 patients, 79 surviving more than 3 years. But what we see is the fracture rate is exactly what we expect, but we start seeing this plexopathy. And it is terrible to deal with for patients. It's a numbness, it's a weakness in the leg or in the arm, and it takes over their entire life. And just, there's no treatment. The one thing that we did realize, if you looked at who got it, there were mainly people who had a second course of stereotactic radiation. So there were mainly re-irradiation patients. There was only one patient who had de novo. So we're trying to figure out what we're going to do with it and how we're going to mitigate it. But that means that we have to draw it. And so luckily for Majid and Hani, they weren't there when we were drawing every nerve root, but now we are. And it takes a long time, but we're following them out. We're tracking them out along the plexus using the MRI and the brachial plexus. It's a bit easier because we're used to it in lung, but it's harder for us. And so now we're trying to spare the nerve roots, at least from a hot spot. So what does it mean in the dose distribution? So here, this is what we would normally do. We get very good coverage. Now we try to limit to under 105%, so no 5% hotspots, but that does break up the dose distribution at the level of the nerve root, and we're accepting this now. And we're trying to see whether or not it matters. So we'll see our rates. Nobody knows how to do this. But everywhere I go, no matter whatever the scale of the center, we all ask ourselves, what do we do about the nerve roots? And this is our solution thus far. Now, some rare side effects also to think about. One is the esophagus, and we're worried about the bowel. We thought we were pretty good on the esophagus, and I really had no grade 3 or greater toxicity ever until this patient. And this was a long volume, okay? So this was like 4 vertebrae. She was breast cancer, oligometastatic. I went through the rationale. She wanted it. I said, I'm not sure the data. Breast is a different area right now in oligometastatic care. But I said, okay, you want to do it, let's do it. And you've got pain and everything. So what happened with her, she developed a tracheoesophageal fistula. So you can see she necrosed, and she died of this complication. And this really shook me up because this never happened. I never had a complication, but I've had one case of radiation myelopathy, but I've never had anybody die from a complication that I've done in the esophagus. One patient had a bowel obstruction that was quite serious, but this is the most serious. Now, what I'm going to show you here is what we learned, and that's what's also important. And although we caused a complication, we've also learned. So what I learned here in the dose distribution is we used to keep it to a maximum point dose for the esophagus. And we'd be fine. We had no problems. I've done 1,700 cases and not one problem until this. And then I looked at it, and I think I was just getting not as strict in my mind of evaluating the dose distribution, because when I looked at the lower dose, that this is 26, 20, and 4, And I said, well, why is it so loose? You know, like I don't do this. My point maximum dose was okay. So we went back and we looked at all our cases where we had some grade 2 complication or not. We applied the new dose limits. So using a 2 cc and a 5 cc, and you can see you can push the dose distribution in and you don't sacrifice coverage. And that's the change that we made into our software. So we no longer think about it just serial, and maybe we should never have it. But we didn't have a dose constraint in terms of the parallel aspect of the organ. Now, this patient also had palbociclib, and I think that contributed to it. Because although it's fine if you give fractionated breast, it's not fine with SBRT. There's data emerging and being reported that palbociclib can increase the risk of SBRT-related adverse effects. So we're looking at our own data. There's some abstracts that have been said. So now I stop it for at least a month. Like, it doesn't matter whatever it is. I mean, it's additional to the hormone therapy. Stop it for at least 2 to 3 weeks before and after, because I don't take that risk. And our center has adopted that because we've seen it in a few cases. So what does it mean for us? So we always look back, learn from your complications. I got this dose distribution. I said, look, I don't like the esophagus. Why are the isodose lines like that? I want sharper dose gradient. We're applying our new constraints to the esophagus. I'm not losing anything. I get a better dose distribution. You can see that 2000 line in light blue coming in, but I still have that 1500 line washing the entire dose of the esophagus. And I'm like, what? I want a better dose gradient. So it may come at the expense of a hotter dose distribution, but now I've got the gradient here and I've got the gradient at the cord, and I'll accept some greater heterogeneity to get that dose distribution the way that I want. And if you look at this, this is after 15 years of doing SBRT spine that we made a big change as a group because we learned from this one case and we made things better. So then what happened was, so we were like, okay, great. Then this patient comes in, and I'm just like, oh my God, renal cell C1 to C6, okay? And he's had no previous irradiation, oligometastatic, and they're pushing me to do SBRT. But I just caused this complication in that patient. I said, I don't want to do it, and then but you got to do the right thing. Like, you've got to trust yourself and you've got to trust your data and what you learned. So we applied our dose limits. We have our new esophagus dose limits to a maximum 0.2 cc, 5 cc, create the dose distribution, it's a sharp dose distribution along the esophagus. And I did it, and it was okay. And this was the entire circle of work. And just, I'm just trying to share with you the things and how, we all question ourselves, and it's good. And you're not sure sometimes, but don't necessarily allow the patient to not benefit from the work that we do. Now, another area is myositis. So this is an interesting complication. Again, one we have no idea what to do. So what you see here is we give SBRT to this patient, paraspinal muscles were involved, and then you see, oh, it hurts in my back, and then you image them, you see all this inflammation, and then in the long term, what you see is this atrophy of the paraspinal musculature as compared to contralateral, and it causes a chronic discomfort for the patient. So if they're going to live, they'll suffer the side effects of myositis, and it's really interesting because we don't know what to do, and and this is an area of active investigation now. So we're looking at sarcopenia, we're looking at various radiomic markers to better understand what to do here, because I don't know that the dose per fraction probably matters. Another area to consider, which is usually never a problem, is skin toxicity. And it's really when you have these posterior element disease and you hammer, you'll see in the long-term telangiectasias and fibrosis. Usually it's not clinically significant. It's a woody fibrosis that they get, in particular when they're post-op because of the effects of the metal on the posterior skin and the scattering that's caused. But overall, patients don't mind it. But something like this happened, and we were like, oh my gosh, so this was an RCC patient, 2082, we've done it all the time. You tend to see with the posterior element disease, 2 years later, just opened up. And plastics, everybody, there's nothing that we can do. Maybe the immunotherapy had something to do with it. So overall, in terms of where we're coming to, in terms of understanding, is that there's a lot of areas that we need to further understand. There's a lot of imaging issues, and we need to standardize. And one of the areas that we've been trying to standardize also is how to understand local control for clinical trials. and just come up with some rules and understanding, because there's not a lot that we know about the imaging. So I'll just show you a little bit of work that we've done, which is just trying to say, well, look, what's tumor progression? Can we measure? So the challenge is there's a vertebra, there's a transverse fossa, there's a pedicle. You have to put the posterior elements together. You're going to use measurements. We've come up with some grading schemes to kind of consider with an RPA where progression is not. And Petra Marilani, one of our neuroradiologists, kind of looked through, 593 cases, and we were able to measure and start to figure out. But it has to be easier than this. None of us are going to sit there and start measuring out so many things unless it became automated. So still work to be done. There's an issue of pseudo-progression. So this patient we treated in the post-op MRI 1 and 2. When you look at post-operative MRI 1, you start seeing some increased darkening of signal and then goes down, just like in the brain and almost anywhere we treat SBRT, we see pseudo-progression. And then you can see true progression, which you're probably more comfortable with. Now, so I'll show you a late pseudo-progression. So this is a patient I treated in 2010 breast cancer, doing great. Gave her 24 grade 2, 2023. That's how long I followed them for their lives. And I saw this, and I'm like, what is this? Like when you say it's probably progression, I'm like, there's no way this could be progression. I biopsied it. It was fibrosis. So those signal changes that you get in your know. Now, when you do know you have progression, like in this patient, this is a 23-year-old sarcoma patient, cervical spine metastases, treated her with 2 fractions, and she clearly has progression. She's got a big paraspinal disease. What am I going to do? So early on, I was just giving powder radiation because I didn't know what to do. Very shortly after, I said, I'm just going to re-irradiate now, but I'm going to increase the number of fractions. So the principles are decrease total dose, increase number of fractions, or both. So we give 30 and 4 as our re-irradiation dose. So we treated her, and she did very well for about 2 years before she passed away from another disease. But this was risky, and this was something where not a lot of places were doing the re-irradiation SBRT. We were doing it because we didn't have the kind of litigation issues like the United States did, and we just did the right thing, and we did it, and then it says. So we published our data, and we showed very good local control. Now, you realize that they're very low-grade epidural disease, mainly 4 fractions. So they're selected. They did good, but if you look at the survival curve, they're really falling off the cliff. So they tend to be more at the end of life. But I was happy to see, because there really wasn't anything until the Japanese group published their re-irradiation group series of salvage SBRT. There really is not any other literature that's meaningful out there. So they showed, again, good local failure, mainly 4 or 5 fractions, and they mainly did 2 fractions at the beginning. So a very representative cohort. But what they found was not myelopathy. What they found was radiculopathy. Very good, very interesting. Again, we're seeing that peripheral nerve issue. When you re-irradiate SBRT, we're really causing neuropathy. Again, it can be disabling, but you're helping them also. You just have to counsel them. No matter how much counseling, the patient who gets it, it's all they think about on their mind. So we've done a lot of work in terms of organizational care pathways, standardized practice in Ontario. The one question that comes up, and we'll come to a close, is how do you follow the patients, right? Now, I do MRIs every 3 months, but that's because my program is there, and we recommended at least every 3 months for the first year. By second and third year, 3 to 6 months, 4 to 6 months thereafter. Nobody knows the optimal frequency of imaging, but you have to image them, and it's a lot for the system to operate to do so many MRIs. Luckily, my system has been patient with me, but we finally have come up with, and these are some data that just came out, to look at high risk, low risk for disease progression and MR frequency. So we have been able to come up with some risk categories based on the SINs, so the spinal instability neoplasia score, so instability, and if you have paraspinal disease. And then we give you risk tolerances now for how much you want to image, low risk cohort, intermediate risk, and high risk for failure. So we're starting to get there for risk adaptive follow-up. And I think that's very important, because not all systems can do it, and we recognize that. But we're getting it. Yeah, the other issue is cost. And you think about it, is SBRT more cost effective or not? Like, it's a lot that we're doing. So we did an economics analysis of SC20 for the randomized study. And in Canada, the cost, the absolute dollar cost of SBRT is higher. So $1,400 versus $500. But when you put into account the benefits, the quality of life factors, and you do the model, your actual quality of life score is about the same. So it is cost effective to do SBRT. So when you look at these quality or quality of life adjusted years indicators, you're not losing with SBRT, if anything, you gain. So it does help patients who are going to benefit. We have a lot of guidelines that we published. We've been endorsed by Astro and Estro recently, the dose fractionation scheme. And with that, we've concluded, and I'm trying to give you a history of the last 15 years of what we've learned of SBRT. But I think now we would say that it's evidence-based care, it's standard of care. We understand the role of dose escalation from 28 gray or 30 to 36 gray and 4. And we have further refinements in dose selection and core tolerance based on our understanding perfect, understanding a fracture. How do you integrate with surgery and do better for these patients? Because there are patients that truly benefit remarkably. And with that, just in case you're ever interested, we do have a master's course for spine. It's online, plus you can come for training hands-on, and we offer that. Thank you very much.
Thanks, Matt. It's really amazing that you continue to develop the wisdom and knowledge over all of these years. So, if you have any questions.
Okay, the wife is a note, so I thought we can ask questions. Yeah, no, I just basically poster. Thank you very much for sharing all your years of experience in 40 minutes. Yeah, so I mean, I was just taking my notes to see. I mean, I have a limited experience over 1 or 2 years, and we've done some severe radiations as well. So I thought I would just clarify a few things which I have been doing. I mean, in UK, we're always behind. In terms of adopting the SIVR, and we have the SIVR consortium, which established the guideline, and we're still very behind. A couple of things. Do you have data for relapse in the index lesion? Like you have a lesion in the vertebral body, and as you rightly said, that all of us treat CT, but there's a GT. So when you look at your pattern of failure, do you have any data to see where is how many times it actually fails in the index lesion?
Yeah, so the way that we've done all of our analysis has always been done in the CTV. Because I don't draw GTV for many reasons. One, it's very hard to see it. And if you think you've got it, with the MRI, the different imaging, sometimes PET will help you, is that you don't really know what that GTV is. So I never adopted a GTV approach, I did only CTV. Now, within the CTV, that's where we've done our patterns of failure work. What we do realize is the bone is less of an issue. So even if your GTV is in the bone, that's the minority of cases where you have a bone-only failure, maybe under 5%. Where you have the majority of failures is the epidural disease. That's the most common pattern of progression. In fact, it's about 2/3. And then comes paraspinal disease. So once it starts to come out into the paraspinal, that's where the GTV is actually matters. I haven't shown the data because we're just analyzing it, but it looks like something like if you have more than 40 cc's of actual GTV outside the bone, that's the marker for relapse in that tissue. Now, distant failure, so in the adjacent vertebra, that tends to be somewhere between 5 to 10%. So we know that it's safe to treat your index lesion. We treat based on CTV only. A lot of places use GTV and CTV. It's just a practical 24S that we don't do it. But if you're treating with CTV, you're rest assured that the question is more that are you over treating? And based on the guidelines analysis, you're not.
The point I was going to come to was that in UK we also treat the CTV. We actually basically follow your guidelines, which you said. And my point is that in other solid tumors, we do have a concept of simultaneous integral boost. So if we are concerned about vertebral body fracture, we're 24-2 or 20-2. And we know that, yes, the GTV is down there, which with more and more advanced imaging, you can more confidently see it. yes, you treat the whole thing, but do you need to treat the whole thing with the whole dose?
Absolutely. It's a great question. So we haven't done SID for 2 reasons. Number one, we know our rates, 10% is lower than most and pretty acceptable when we look across the board. So we don't think we're causing more harm. It's going to be hard to cause less harm. So we haven't really escalated. When we went to 28 and 2, we thought about doing 24 with the 28 to whatever we thought would be GTV. It's just once you do the dose distributions, like they start to bleed into each other. So you're gonna save on the mean dose, okay? But you're not gonna be, whatever anatomy you're gonna spare anyway with your CTV delineation. It's just, does that mean dose to the rest of us? And it might. None of the data have really shown that the dosimetric factors associated with fracture. We just haven't validated it, but we're gonna get there. So MD Anderson changed their approach. They do a 16 or 18 and 1 with a 24 GTV. Sloan Kettering does exactly what we do, but all to 24 and 1. And I just don't know the answer yet. It would be a great randomized study to do, but it's something that we do think about. My thing is just, it's just safer. And if you know your outcomes, you're okay.
Yes, I mean, I'm not talking about the de-escalation. I was actually talking about the escalation.
That's right.
So, yeah, so like 0631, we showed like 1/3 local relapse.
Yeah.
RUG. So what I'm saying is that would it be still safer to run a trial where you still give 24 and 2 or 20 and 2 or whatever you're doing, expecting the amount of fracture that we have, and yet escalate it even more significantly onto the GTV to cut down the relapse rates?
Yeah, I agree. So if you were, say you were to do 0631, you wanted to give 16 and 1, and that's what the Cleveland Clinic still kind of does, but they changed it. So if you said 16 and 1 is enough to your uninvolved bone, but let's give 24 to the GTV, and that's actually a sort of, that's on study right now. So they're looking at a prospective phase 1. And again, we'll see whether or not it matters. If you look at the SIV data, exactly what you're saying, which is a perfect point. The fracture rates, nobody has under 10% anyway. So it's just hard to prove. So it's just, for us, it's a big deal to change. But I think if someone was starting out and said, look, I'd rather do this, I think it'd be perfectly fine. As long as you're going for the minimum is there, but escalate the dose of the GTV. And it may only matter in some histologies, that's the thing. If anything, I'd like to de-escalate our dose for prostate and breast and the hormone sensitive. So we have the randomized phase 3 to complement SC24 is written, the protocol is written, it's approved, it's going to start. It's in non-spine bone mets. And we allow 30 and 5 versus 20 and 5. That's the randomization. But they like to find radiosensitive as hormone-sensitive breast, hormone-sensitive prostate, and breast cancer check. And so that's how I changed the radio-resistant. We didn't go for an escalation or not, it's too hard to study, but the point's well taken.
Just a very brief, the second part of the same question was that when you say that the recurrences are either paraspinal or the epidural. That is why my question was that are we still too scared of myelopathy? And in your experience, what is the incidence of myelopathy? Well, I always believe that our grandfather Imam told us that this is what our dose tolerance is. And then, of course, Ponte came in at those times.
Yeah.
But I'm not sure whether there is any valid biological data to really know the core tolerance. And are we too scared to let epidural recurrence happen?
I think we are in general. So it's that the fear is real. I mean, it does happen. So it's happened to me, I think, twice now. But I'll tell you, in terms of my view on core tolerance, and Majid, you can correct me, because Majid wrote a chapter with me on this for is I think 60 and 30 is about a 1% or less, but it's actually about 1%. Now, I take it to 70 gray and 35 fractions on chordoma to the cord, and we'll do it to the cord PRV. And we've been okay. We haven't caused it, but it's chordoma and it's rare and there's few. There's maybe I've done maybe 100. And maybe about 60 cases, which is a good experience. And then once you start to get to hypofractionation, that's where the 14 and 1 is real. It's a 5% or less risk tolerance. It's hard to know because of the nature of the population because they don't give it in the benigns. And if you look at what the single fraction people do, they may say you're giving 14 months, but they're not. That's their upper dosing. They get 10 or 12 max, because they don't want to take the risk in the benign. In the Mets, you don't know, but it's under 5% of 14 months. And it's real because they've reported it. We know that they get it. And so we have taken an approach, as you suggested, that we were conservative and we built it slowly. And now we're at 19.42, but that's where I got my line. So I think we're at the cusp of where it will happen. The true incidence is hard to know in terms of percent, but now at least I know when it will happen. I never saw it at 17. I didn't see it at 18.7, but when I took that last jump, which was 19.3 in the context, and I wrote that, and I wasn't sure because it was a model, but we said high-grade epidural disease radio-resistant, we're going to go for it, and I got it. So that's under, and that's maybe about, in total 1,800 patients there. So it's rare.
Do you have a comment on reapplying TG101 constraints?
Yeah.
There was one very funny constraint on it, which me and my physicist always had this argument with Governor, of course, he came from US. And that was most of our patients are on 5 fractions. Right?
Yeah, that's the majority of the world is.
Yeah, so 5 fraction constraint for 1.2 cc was 14.5 ray limit for 5 fractions, which to me did not make any sense. 14.5.
Very low.
I said we treat 20 and 5 for the whole big long talk. So how about 14.5 for 1 cc?
Yeah.
And TG101?
I never followed TG101 anyway, but even Timmerman's numbers are based on what he thinks. Ours are a bit harder, but I'll tell you, what I've realized over the years in the different, and it really kind of came in terms of the peripheral nerve versus segment. The spinal cord is an organ in series with a small parallel control. So if you're going to take that point maximum dose above 30, okay, or even 30 and 5, now we take it to, I think our upper dose is 27.5 and 5 to the core PRV. But if you're going to go higher, the low dose bath matters, the intermediate to low. Now that's still, I'm surprised that the numbers that way, but that's where it matters. So that intermediate dose that's looked at by the spinal cord will influence the tolerance to your point of maximum when you've escalated to the brink of tolerance. What we do, where we keep it is a bit lower. And I treat 4, 3, 4, 5 levels, and I've never even looked at anything other than the point of maximum. And I haven't had a problem. And even the case that we had was with a single level. However, in the peripheral nerve, it's different. It's more of a parallel structure where the volume matters. In the cord, the volume doesn't matter. And that's why when you look at the incidence of lumbar sacral plexopathy, it's all in brachial plexopathy of lumbar sacral, it's all in lumbar sacral. Because when you go L3, 4, 5, you're treating a long length of the actual nerve because it drapes over the lumbar spine. And that's where the volume effect is coming in. And that's what I've started to realize between the brachial plexus and that, because I hardly ever cause brachial plexus injury, but I cause lumbar sacral injury. So I would tell your physicist not to worry. I think there is no volume.
From all levels.
The volume effect is not there. It's just, I haven't seen it and I would have found it. I treated 4-level cordomas. Yeah.
And maybe one add-on question, very relevant, the Dmax, because I do on LINAC, I do on Cyberknife. The Cyberknife, the physicists working on the Cyberknife, they always tell me that the voxels are very tiny. So the whatever gives you as global Dmax, if you take the same plan and calculate it on Eclipse or Monaco, it will be less. So Cyberknife is more accurate. So what is the definition of the Dmax? Has there been any changes in the?
Well, you can tell you all the initial work that on radiation tolerance that we did, all the plants were Cyberknife plants, but those were pre-Monte Carlo days. So at least now, Cyberknife, the new treatment planning system has a better dose calculation actually than before. There was no even homogeneity. It was all homogeneous. There was no heterogeneity connection. So that was a long time ago, but that's where the numbers came from, which were Cyberknife numbers. Now, we use a Dmax as a strict Dmax that you get off. You mainly use Pinnacle. However, I would feel quite comfortable going to 0.035 on the PRV. Because there's enough experience there with a good dose calculation algorithm, you're okay. But at the end of the day, the safest thing to do is to just take whatever the true Dmax is to a box zone. Because that's the data, that's what we know. And that's what we do, so I can't, it's a big, it would be a very big change for us to do that. But some places go to 0.035 cc's and the APM recommends it, and but we're just worried. If you're gonna do the true core, then I would do Dmax. If you did the core PRV, I think you're okay for 0.035.
There's one other question. Because we are getting more and more into the re-irradiations. We recently had a patient with third re-irradiation and fourth we took it out. So, yeah, so when you say 75% recovery, so does it come into your calculations, cognitive calculations, when you're deciding about the dose of second and third re-irradiation? That, okay, when you decide about what dose you're going to give, you look at the previous one and you say, okay, 70% recovery. Does it really physically you drop the dose down?
No, it just allows me to do it. So I use my re-irradiation numbers and we just follow the number. Before I used to sit down and do all the math and I can't do it. You know, like, those days are over. So I just use those numbers. But when you deal with somebody who's had 60 gray and 30 already, and then you want to re-irradiate, I try and take into it gives me this, it gives me the sense of I'm all right doing it with a 70 gray total EQD2 tolerance. That's really where I put it in there. But if it's going to mean a really underdose, I don't do it. I just follow my number and it goes a bit higher. There's a Korean experience that went higher than mine. There's another center also that I think they're one of the German centers. There's a variation. And so in that scenario of Mets, I'm far less worried. In the primary, that's where I really start to work. But I use my numbers and I just use them.
Yeah, but we create the plan sum.
Yeah.
And in the plan sum, we'll look at those numbers.
To 70 is a good number. Like over 140 BD, you're safe. At 140, you're safe for sure, cumulative. Once you get to over 160, that's where I get nervous. But 140 to 160, I'm not that bad.
So we look equally to, so if we do about 70.
7, yeah, and that's what we recommended the first time.
Excellent.
Can I ask another question because with connovation, in this case, after you check many they come straight, do you like to change the fractioning or not? Because this is another question, you know what I mean? Because normally we like to increase the number of fractions, but it's more safe.
If you're already doing 5 fractions, you're already there. For us, it's about going from 2 to 4 or 2 to 4 to 5. So on the second time re-irradiation will do to 4. If I go third time, which we do, then I'll do 5 fractions. That's how I do. We never do more than 5 because then you're getting to time intervals from the imaging and you don't know how things are changing. It's much more important in brain mets than spine mets. If you have epidural disease, you just don't know. And so that's how I do it. So it's either 2, 4, or 5. Now I have done 4th time, and I've done it maybe 10 times, and it's never gone.
Okay, on the same vertebra.
It's not gone well because of the toxicity. It just patients are dying. You just can't. It's not. Yeah, there's no substitution.
Can I ask you a question relating to the number of fractions now? Because like we said, we use the 5 fractions based on the UK protocol. Okay, but we know that a lot of centers, even Italy, they do less fractions. They are more aggressive. So my question is, do we feel that the number of fractions you do 2, 3 fractions?
2.
So 2, exactly. So 28 2 fractions, for example. The standard.
That's good.
Do you feel that in any case, when we do 30, 35, 5, sometimes can decrease the toxicity?
Yeah.
Like for example, in the case of the trachea, where you show the fistula.
Yeah, I would have. I already did 4, so I was already trying to mitigate the risk in that patient by going to 4. It's just that intermediate dose line. I think I screwed up. You can see it, and the palbociclib I think contributed to that. But I think you're already doing the safest thing possible.
Yeah.
Going to 5. Now the UK guideline is taking 24 and 2. Now they changed their.
Yeah, so in UK, most people are doing 4, but we are We are currently, right now, we are doing 40-5.
Yeah, oh, that's a good joke.
75, we're gonna do the
So what we are doing is that 40-5 and 35-5. So 35-5, the whole day thing on your targets, which you have the addresses,
And then 40.
and 40-5, that's PET driven or MRI driven GD.
I think I would do that for radio-resistant histologies, and I would do it for high risk, big, like ones where you know you're gonna fail with big paraspinal. However, on lower risk, let's say, for example, prostate cancer, breast cancer, I would do 30 with the 35. I wouldn't go to 40 and 35 on those patients.
I mean, I borrowed it from, I mean, I don't know if it's right thing or not, but in prostate SBRT, I mean, a lot of prostate SBRT, and they all were 40-5,
Yeah.
prostate at 36.25-5.
I think that's okay for the prostate gland, but in the bone, I don't think you have to take the risk for breast cancer and hormone sensitive prostate cancer for sure. Castrate resistant, I think you're okay, but I wouldn't take that risk because you are increasing the risk of fracture a little bit more than you need to. And the breast, I haven't shown you our breast data because we're writing it right now. It's unbelievable. Like it didn't matter the hormone status, this and that, 95% local control. However, for epidural and paraspinal, we're still seeing the trend, but you're still like under 10% rate of failure at 5 years. So
35 or 30, you would recommend.
yeah, I would go 30, I would de-escalate on those ones, but the rest of them, that's an excellent dose, 40 with the
So
35.
most of our prostate, we don't treat upfront hormone sensitive oligomers. Most of our patients are castrate resistant. Technically, we call them oligoprogressive.
Yeah, I would do it.
So those are what we mentioned.
Yeah, we do a lot of upfront.
What's the time lapse between the first and the evaluation?
So what we did was when we published the first guideline, it was 5 months, but that's what my mentor taught me, and that was his data, but my experience is his from the beginning. And so the soonest I'll do it is 3 months, the soonest. But I think 4 to 5 is better, but the soonest I'll do it, I'll never do it at 2. Because you don't get the repair. We know from the rat experiments from the 1960s, that you don't get it by 2 months. But the soonest I've done 3 months, and I kind of usually regret it.
I think it is 6 months.
Ideally 6 months.
And in terms of delivery day, you know, you were mentioning it's Tuesday to Friday, you know, do you treat every day or you give a break?
Every day,
Every day, even when you do fracture?
I do every day for all bone. Now, benign brain, I do every other day.
Okay,
Because it's benign brain and you know, let them get a little bit of a break. And then in high-risk patients like the C1 to C6, I did every other day. I did everything possible to mitigate this.
without any issues, because I have, you know, sometimes you alternate once a week, you without any problem every day.
Yeah, oh yeah, once a day, I think for bone is okay. You know, but if you're high risk, re-irradiation, the word long lengths of bowel mucosa, every other day is okay. It's just, you can't let things get too long, because you're already getting 5 lectures. So I just do it daily.
So
You're gonna get a weekend most of the time anyway.
other than cycle experience with that much toxicity, is there any newer drugs right now in your practice which you definitely will stop?
The main ones are the adriamycin, the doxorubicin, and now palbociclib. But the rest of them, but the other ones are the osimertinib and the amino. Amino now I'm comfortable, I'll treat through it. I just don't like the infusion on the same day, but otherwise it doesn't matter. The TKIs and especially the BRAF inhibitors, I'll hold 2 days before, 2 days after for no good reason. I just don't know with the TKIs. But with the BRAF, I do know you should hold it 2 days before, 2 days after. Otherwise, in terms of sequencing with chemotherapy, I just do it on and off.
Yeah, just one question. You consider secondary catering and those distortion from titanium efficiency function?
Okay, it's an excellent question. We've done the work. So we look mainly in the spinal cord. And we know it doesn't really make a difference. When you use multiple beams, it all cancels out, and we did a spinal fend. And we did it. So now that they're using more carbon fiber, can that reduce it? It might a little bit. I've seen the data, and we've read the papers. It's hard for me to think about it there, but superficially, I think that's why when you see a post-operative patient, you see the hardware, and then you see them 2 years later, and exactly where their hardware is, you see the changes in the actual where the screws are. Because that's where you're getting the dose perturbation effect. That's where it's hitting the superficial skin and you're getting more. So it's on the entrance. But the nice thing about the corridor for us, it's in the exit, right? So by the time it gets in there, it's probably a little bit less. So at least we've done the work, but it's a bit of a gray area. So I get nervous doing 19.3 in a post-op, doesn't matter, whatever it is, on the core PRV, I try and go to 18.7. But if I could do more carbon fiber, I would.
Thank you.
When did you use prevention fractionation? When you stopped using?
How, so the only time I ever use 8 grain wine for someone who's gonna live under 3 months, no problem. And then breast cancer, hormone sensitive prostate, look, I talk to them, but I don't feel very strong. I would just err on the side of giving them
So-
conventional, yes.
So he means by completion of 8th grade symptom. So
Yeah, under 3 months of life, otherwise I never do. Yeah, or there's some real reason like that, but otherwise, I don't know.
Okay, so we have, I think, for some people need.
Oh, yeah.
I would like to invite everyone for a picture, group picture. And we do have a couple, now we have like a case that we like, oh, share with you. It's a new patient that we're actually receiving. So it's, so it's a cordova case.
Oh, good.
Who, we only to go to protocol, but he can't afford it.
It's a good idea.
So we, you know, but let's check out all together for a group picture, and then we can, whoever can.
So when you're, going back.
Wait, can you please
we missed the initial part.
لا لا رجعت سجلت.
بس أقصد البداية we missed it.
ايه اول شوي. اوكي
طيب.
رجع شوي لورا.
أهلا. Thank you very much. We still 5 more minutes.
Okay.
ساعة كم ولا هو ماشي؟ الحين خلاص بنخلص 5 دقائق بكرة. واحدة من الكامل. So yeah, have a seat, please. Yeah, so just maybe 5 more minutes, and I prepared like 5 cases. I don't think we can go through them. It just so this is actually a patient that he hasn't started. He's 39 years old. Guys, Brahim, yellow. You're getting late, guys. So it's so 39 years old. He's a young fit and everything, and he presented with diplopia, and then he was found to have a clival mass that was resected with a residual disease, a very small residual disease, and it turns out to be chordoma. So so anyways, we're planning him. He's supposed to start tomorrow. So if there's any changes, we can still make it. Our physicists will hate me. So sorry, he's 42. Sorry, 42. Sorry, where is that thing? Here we go. So basically, what I did was the GTV is residual disease on the post-op planning MRI, and then CTV 78 gray was 5 millimeter on top of the GTV, trimmed from anatomical boundaries. And then the tumor bed plus on the preoperative imaging plus 5 millimeter trimmed from anatomical barriers. This was the CTV 7000. So I'm giving 7078 boost SIB to the gross disease, all in 39 fractions. So I don't have the, we just actually I just asked my physicist to pull up the planning things. So we're covering the 2 doses. There's so this is the residual. It's more obvious on the other.
Those are the only isotopes lines, yeah, okay.
So this is 95% of the 78. And the other one, which is what is green, is the 95% of the 70. So there is underdosage close to the optics, of course, and the brainstem. So I showed the planners the chapter that we have those constraints, but it seems like we're not very comfortable with pushing the Dmax to 64 or something on the brainstem and optics. So what we have now here is this is after a few modifications. So if you look at the CTV coverage, we're getting the 70 is getting 94%. And here 63, 90% of the low dose volume. PTV coverage is 90, 85.
Okay. So what I would say, Najid, as I would go up on your brains, how much is your PRV?
2 millimeter PRV.
I would definitely go up. I think it's two shots.
This is 59 gray to the brainstem
And
PRV.
that's in 39 fractions.
Correct.
I would tell them, look, your BD, even if you need to do that, tell them that you're already lower than you are with 60 and 30. So give me 64, I would take it to 70 to the brainstem PRV. Your optic chiasm is perfect, 60 gray, and we rarely go over that, and that's nice and safe. 60 gray on your optic chiasm PRV is safe, is 42, I understand that. But your brainstem PRV is, they have to go at least to 60, 64. I mean, it should take 70.
On the PRV.
Yeah, on the PRV. If you said, give me 70 on my brainstem PRV, I'll take 64 to the actual brainstem, and then in the center of the brainstem, you want 56. And so then that way you've got a gradient. Because if you go back to the distribution. My only comment to tell them is say, why is the 36, right? 39 grade coming out like this? Why is it not hugging the rest of the isodose lines? Why aren't they putting a dose sculptor in there and pushing it up? So I would be maintaining your gradient. And that goes back to your question, which was, does that lower dose volume matter? Probably, once you're pushing it to 70 and a higher dose, that's where it matters. But there's no reason to expose the entire brainstem to your intermediate dose. I'd be pumping that up. So create that upside down U shape over there. And that's what I learned from the esophagus case. But that I would do routinely. And that's why if you tell them 70 to the PRV, 64 if they want to the brainstem, and 56 to the center of the brainstem, then you create that shape and you get that nice gradient moving. And then the rest of it looks really excellent. I mean, one more can do. What is the cochleus?
If you go back to that table, wasn't there a misprint of brain? So you're allowing the criteria for brainstem PRV of 62 grade, is it?
Yeah, so his is, no,
Brain
your max
are
dose,
around 70.
your max dose here is 59, 60.
Then I'm talking about the criteria on the right side, which you're following.
Oh, no, yeah.
Scorecard, yeah, on the right side, on the, yeah, in the last page. So, I mean, brainstem, your criteria is much larger dose than the PRV, shouldn't go other way around.
Well, that's probably, well, what's your PRV?
PRV is 62 and brainstem is 70.
Yeah.
Shouldn't be anywhere.
Yeah.
It could be looser, but they're just lower in either case.
I'm wondering if typos should be other way around, like.
Yeah,
I think
probably.
it's just because you're lower, so you're getting the green light because you're already lower than both.
Yeah.
My question is, what do we focus on? I mean, instead of going over, we need to build a scale that happens. This guy went for one, right? So, and, you know, I mean, Dr. Falah knows more than anyone else the practicing here with UAE. You know, here, if a patient cough, they were not supposed to cough, you go and report it to the DOH, I mean, they lie. So report, it's a cultural thing, you know? So again, one of the reasons why we're not educated is that we really sensitive. We're very much scared of crossing the boundaries. And again, I see sometimes, you know, now we want to push the rules, but we're concerned about, you know, what if this guy after 3 years developed, you know, a complication and he goes to any radiation oncologist who can easily tell him, oh, you know, the dose that was too high on you, and then this guy goes to do it, even if they just sometimes honestly for the money. So this is where I think practicing medicine in the UAE
And I think,
difficulty. So my question is that what should we, so this is technically the Emirates Oncology Society that we kind of work with, right? So this is where we need to set the consensus.
that's exactly what I was going to
Go
say.
for higher dose and take this, or should we play it safe?
Well, you know what I do is I tell the guy himself, and then I put in the medical record. I can give you this plan, you know, and this is a very American way to do it, right? They show them the plan, say, I can give you this plan, this is what happened, I can give you this plan, let the patient decide. So I tell the patient, listen, you want to take a 1% risk of brainstem necrosis, take the 70 plan. You want to take a 0.1%, or you could say 1% and 2%, doesn't matter, pick it up, and say, you could take this plan. If he chooses the conservative one, you're covered. If he chooses the less conservative one and he understands the issue when you fail chordoma, you die of chordoma, then you take that one.
and I dictate.
Then you are safe.
Then you say, I put it in the record.
I think you can start with the, so you start with the standard, and then escalate as we get more experience. And get more consensus and more, experience.
So now we're mandating peer review, right? So now we're actually making peer review and, believe it or not, that's quite new, right? So, peer review and to try to, I've learned a lot. A lot of the cases I thought I was doing it right, measured and repeating, came and corrected me and vice versa. Yeah. So that being said, because society is very small, because the patients goes around different sectors. We get patients a lot who come in, they do their simulation, do their planning, and then after a week, discover that they're somewhere else, they get treatment. Yeah. That being said, what do you guys think about, should we start with the statement of those escalate? Should we try to push things? Should we give 2 plans for each? I don't think we should decide. I don't have that, which I think is the easiest way and most effective, but it also takes a lot of effort and time from physics and this.
You don't have to, you could just tell them.
Yeah,
You don't have to show them.
yeah.
And actually, this will take me to the other thing that we want to discuss as well. I think, as Ibrahim mentioned, we are like growing community of radiation oncology, and we're trying to combine both societies of Saudi and Emirates Society of Radiation Oncology so that we can come up together with some joint efforts. And actually, because of the private sector is growing probably in the radiation oncology as well, in both in the region, there will be a lot of the concerns related to malpractice and those litigation stuff. And then the easiest thing, as Dr. Ibrahim mentioned, is that when the insurance company and the when there's a case that they want to discuss, they will go to a random radiation oncologist who knows nothing about CNS, for example, and he would pull up the Quantic, and then he would go with the Quantic. And here we push the dose much more than Quantic, for example, and then he will be in trouble. I think this takes me to the question. I want to get your opinion, Arjun, on this. Do you think, as a small community in 2 countries, we want to grow together? And do you think having guidelines, just like the UK, what they did UK, Canada, Australia, and the US, they do have some guidelines on decision making, like for example, spinal metastasis treatment, and then you kind of have some decision trees and that kind of thing, and then the technical aspect of the spinal SBRT, for example. And then that way, if we have this consensus guidelines, we can adopt it through the societies. And then if there is any problem, then everybody is backed up by this statement or this consensus. Do you think that that's something that?
I think you should do it, and rather than reinventing guidelines, if you as a society come together and endorse the guidelines, okay? And then you have the Saudi Journal of Radiation Oncology.
No, there's.
The Middle Eastern Journal of Radiation Oncology. Yeah, then if you put in a letter saying we endorse these guidelines, and you as a society go through, there's a formal way to endorse this stuff. So let's say you want to endorse the ISRS guideline, you apply, or the Cancer Care and Terror guideline, I did this one. You apply, you do it, you do your own, you recommend, you endorse these guidelines, you put a letter in there, and it's on the record, and you've endorsed it, because it takes so much work to.
Exactly, yeah.
It's crazy, but at least you can endorse them. And then you have the protection, and why it's more important, because as the private sector comes in, they're gonna do things really bad. And so you're saying that this is the standard that we all agree on. So spinal SBRT, we have that, we have the UK just coming out with theirs, Astro just came out with theirs. That was a very comprehensive document. They said, we're going to endorse this guideline, this is the standard of care in the region, you guys all decide. So when the private sector comes in and they start doing things that no one's ever doing,
You don't need to, we don't need to,
Yeah.
we take the already made guidelines that suits us, I think, and then like we follow NCCN guidelines. I think we should just pick up one of our as to or that, and that's, yeah, that's it.
I have a question regarding the contouring for the cordoma. I know that practices is to do the 2 CTV 70, CTV 78. But in some series of that, they are just treating the residual with maybe radiosurgery alone, and they reported very good local control, range 50 to 80%. So can we just treat with SRT, similar to what Majid did? We just focusing on the residual disease, no need for the.
The way that I approach that, and I approach it the same as atypical meningioma, okay? Is that if you're doing upfront adjuvant, do the two dose levels. That's the way we do it. We actually I used to treat 78 to everything, because that's what I was taught. Now I do the two dose levels like the way Majid and I wrote about. And it's safer because you don't need that much on the but you need at least 7, right? The Chordoma, International Chordoma Guideline, which was led by the Italian group, they said 74 is the minimum. They didn't put the number of fractions. So at the end of the day, you need it in the adjuvant. So let's say he recurred or she recurred 5 years later with 1 GTV, then I would just treat the GTV and I'd do radiosurgery. And that's how I do atypical meningioma. So adjuvant, we give 60 and 30 if it's close to a resection. We simultaneously integrate boost to 70 and 35 if it's adjuvant with residual. But if it's 5 years later, I'm not going to radiosurgery. Because then the problem is in those series, right? You know who wrote those series. They didn't tell you about the distant failure in the surgical bed. They just reported the local control. They don't count the failures that they reoperated on and they did, and that's the hidden part of the literature on those series. Brain pharyngioma, same thing. It's a 95% local control. They don't really fail all of the other.
What do you consider stable EQG for rates?
7. Point that 70 lipid radiation. So you do 70, and then you just follow the dose grading in there. So your center of your brain stem should receive 56, and your surface receives 7 in your signal. Normally, I would never have a complication. 60. I don't go over 60. Like even if I'm going to that, at the end of the day, that's where they'll come in after you. Can I give a vaccine?
Yes.
They just have to be consented probably, but if vaccine doesn't work for the they just go.
Okay, so already 9, so we have a 5-minute presentation.
Oh, good.
And I would like to thank all of you for coming, despite that it's Ramadan and you know that. But we couldn't let Dr. come and go without having him for this lecture. So we'll have 5-minute presentation by Joel Park.
5 minutes.
And then I think.
And this presentation is regarding our skin condition we showed.
Oh,
It's relevant.
That's where the people start.
Because I think.
Maybe ointment, then we work up.
No, but we showed the scar where the late effect was, so people start.
There's no.
Actually, this presentation, first of all, allow me to thank you. It's such an honor to be among you tonight. All of you, thank you very much. I'll be taking 5 minutes. Why I'll be taking 5 minutes? Because this study, we already presented many times to Mediclinic City Hospital, to ACOC, Dr. Falah was there as well. In Bourjil, we presented the study also in Bourjil Hospital, if you remember, Dr. Majid last year, also to your team. And also, of course, Dr. Ibrahim is very aware about the study because he was one of the soldiers of the study, I believe. The study was conducted in Lebanon. Yes, I believe some of your patients was among the patients. Am I right? Yes, in the study. So everybody is aware. I just took the chance to just remind them about our product. But before talking about our products, it's in your laptop, yeah. Misha, I'd like to introduce myself. My name is Rayan Abbas. I'm the marketing manager of Mibo in the GCC countries, UAE, Kuwait, Oman, and Bahrain. Today, I just like to take 2 minutes to talk about Julfar and 3 minutes to talk about Mibo, because I know your experience on Mibo is way more than my experience on Mibo. Julfar is an Emirati company. We produce our product here in the UAE. We are present in the market for more than 40 years. We have 13 world-class manufacturing plants based in Ras Al Khaimah. We produce every single day. We produce every single day 500,000 boxes of medicine. Every single day here in Ras Al Khaimah, 500,000 boxes of medicines are produced and exported to more than 45 countries across the globe, providing the region accessible, affordable, and of course, effective product. We have many divisions. We have the PPI divisions, all PPI that you can thought about, like esomeprazole, omeprazole. We have all the range of antibiotics. We have cardiovascular, we have CNS as well. But tonight we took the chance, as you can see here, to talk about MIBO and which indication. MIBO is known for you as a burn ointment. Am I right? Maybe Dr. Arjun doesn't know MIBO because he's based in Canada. Hopefully one day we will have MIBO in Canada. But actually, we have here Dr. Hani in Saudi Arabia. You do have the MIBO, and you have experience on MIBO as well. So it's well known. Actually, Dr. Arjun, this is an herbal ointment composed of sesame oil, beeswax, and beta-cytosterol. It's present in the market from more than 27 years. It's actually for burns and wounds. From in 2015, from 9 years, we approached the American University Hospital in Beirut, the radiation department. It was under Dr. Fadi Jaara, who now is based in Cleveland, to ask them to try the MIBO for the patients having breast cancer for acute radiation dermatitis. Because we believe through the feedback from the doctors that it's very beneficial for the healing, for the pruritus, and for the pain, which is the most common side effects reported by the patients. In this center, they are highly scientific. They refuse to use or to try me without conducting a clinical trial. And from here, we got the idea to conduct through the American University of Beirut a clinical trial. But actually, it was a comparative clinical trial because their standard there was biafine. I don't know if you have any idea about biafine in Canada, but here in the UAE, it's not available. It's available actually in Europe. Mostly it's used in Europe. The study was published in the American Journal of Clinical Oncology. It was conducted on 161 patients. Half of them use MIBO and the other use biafine. Biafine is strolamine. It has hydration properties. And why they are using it in University Hospital of Beirut? Because they already have a clinical trial conducted in France, and they use only products with proven efficacy. That's why we conducted the trial. The bottom line, because as I said, all the attendees here already aware about the study. The bottom line that, as you know, and I think I try to understand the lecture of Dr. Arjun. It's quite difficult for a marketeer, but I try to understand. But your main goal is to give the patients a better quality of life, like palliative care for the patients who are terminal, but the breast cancer patients are not terminal. They still have life. They go to the work. The dermatitis can be irritating to the patients and can affect their quality of life. In severe cases, it can cause interruption of the radiotherapy treatment course, resulting in long delays, which could affect treatment outcome. Do you agree with me? Here comes the role of MIBO ointment, because at the end of the study, the use of MIBO ointment was associated with decreased severe pruritus and pain, which positively affect patient comfort and quality of life. The analgesic property of MIBO has been supported before, but through this clinical trial, you can give MIBO to your patients starting day one, as the doctors are using it. I believe Dr. Rana, Dr. Patricia, they are using Dr. Brahim as well. They are using, and Dr. Majid also is using MIBO. And here we have Dr. Dennis, we just talked to him about MIBO. You can start to use it from day one, not to wait until the patient develops the acute radiation dermatitis. They can start to use it from day one, twice per day, the whole radiation treatment, and 2 weeks after she finished. That's it. Thank you very much. May all your patients suffer less.
Can we use tahina instead?
Thank you very much.
Thank you, doctor. Thank you for this opportunity. Thank you.
Thank you, Arjun.
أعطيها الإنجليش 4 يجربها.
We can try it also.
دكتور